Welcome to the Death Happens podcast, an insider's guide to dying. We're your insiders. I'm hospice nurse Penny.
And I'm Halley, hospice social worker. Today we have Lisa Yeager. She is a psychedelic assisted psychotherapist, and we're going to get into what all that means in a minute. But first, since we're talking about drugs, I would love, Penny, for you to tell us a bit more about the medications that we use in hospice, and specifically the medications that we use that have illicit street drug use that really freak people out.
Right. So, first of all, let's talk about the comfort kit, because the comfort kit has morphine in it. It also has lorazepam and Haldol, and that's pretty standard across the country. Most hospice agencies have at least those three drugs in their comfort kit. And interestingly, now the morphine, of course, gets the bad rap all of the time. People think we give morphine to end people's life. And morphine actually is less potent milligram for milligram than oxycodone, which is what is in Percocet. But the other one that's kind of interesting is the haloperidol, because haloperidol is an antipsychotic medication. And
Yes.
we use it for other purposes in hospice. We use it for nausea and vomiting. It is like one of the best. It's my favorite for nausea and vomiting. We use it for hallucinations if patients are hallucinating. We use it for agitation. It works very, very well. But people are very concerned when they hear we're using haloperidol, if they do any kind of research, and they're like, oh, that's for schizophrenia. That's, it's stigmatized because it's an antipsychotic medication. It's a psych drug. And so people worry about that. And in fact, when we have patients who are in nursing homes, it's very challenging for us because they are not now in the state of Washington allowed to use haloperidol unless a doctor is seeing the patient every week. And so it's kind of a real problem for our patients in nursing homes. But other drugs that we use that are stigmatized are methadone. Especially, I don't know how it is in other states, but in the state of Washington, methadone has been used for decades and decades as a replacement for heroin. It's a way for people to get off of heroin by going on the methadone replacement program. But methadone is a very good long-acting medication. It works very well for pain. It works well for neuropathic pain, and we use it often. But again,
and less
it's another
constipating, right, than other opioids.
Yeah, less constipating, and it's really effective, and it's a liquid. It becomes real concentrated, so people can take it by mouth even if they're having trouble swallowing, and it can be given in a MACI catheter. It can be injected. I've had a person on a methadone infusion. It's a very, very effective drug for us to use, but it is very much stigmatized. Fentanyl is another one that is really stigmatized. Fentanyl patches are very commonly used in hospice because if a person can't swallow, slap a patch on them. But it is now a street drug that is killing a lot of people. And so it's stigmatized. Now, one thing I will say about fentanyl patches that is important for people to know is that those patches are good for 3 days, and you take it off and you replace it with a new patch. The patch that's removed after 3 days still has fentanyl in it. And there have been situations where somebody had a patch, they did not dispose of it correctly or slipped off the person's body, and a child got a hold of it and actually has caused the death of at least one child that I read about that was exposed to a fentanyl patch. So it's really important to be careful. People don't think of a patch as being a really potent medication, but it absolutely is a potent medication that we use. And as long as it's used safely, then we don't have to worry about the patients, being harmed from it. And I think that's kind of the important point to make here is that when medications are used in hospice, they are prescribed by a medical provider and we use them safely. The intent is never to cause harm to the person or to cause them to die faster. It's meant to relieve them of suffering from their symptoms by managing their symptoms, not by ending their life.
Yeah, we don't hasten, we don't hinder. And the benefit of the hospice program, and this is how I explain it to a lot of folks, is we move a lot faster to be able to control those symptoms because we have access to our doctors and our nurses and everybody's so involved and you don't have to wait a month to get in to see your PCP to get a refill.
Mm-hmm.
We're also treating end-of-life symptoms, and they require more management, more medication. And so you're seeing larger amounts as they're going through their disease process, but it doesn't mean we're doing it to off them sooner.
Right. We're not blasting them with those big amounts to start with. We're ramping up as we need to. And with cancer patients, oftentimes we have to ramp up pretty damn high to control the kind of pain and suffering that they can have. And the other thing that's important about hospice, I've seen some comments lately about people saying that people that are dying should be able to get the medications that they need, and the federal government is not allowing it, blah, blah, blah. Hospices are not beholden to the same federal laws around opioids. We do not have to follow the same laws that other clinical practices have to follow. We have completely different laws, not completely different laws, but those laws do not apply to us. Like those limits on medication.
Different restriction guidelines.
Right, exactly. Different restriction guidelines. Those laws, those restrictions do not apply to hospice. We are able to get the medications that our patients need.
Unless, and this is my devil advocate, and you already mentioned it, if we are in a skilled nursing facility, they have regulations that we then have to work around with the facility to figure out what they're able to give. Assisted livings in particular, because they only have med techs and not nurses. This is something that's been a long time struggle. It's not mainly me handling it, obviously, it's the nurse, but I've been part of that conversation where we can't have PRN, which is as needed, or we can't have, it has the outline of the as needed medications has to be extremely specific, or they can't use liquid. They have to crush a tablet because they're not able to pull up a syringe and measure. Yeah, I get it. I get it's for safety, but good Lord.
Yeah, it's a challenge for sure.
So it's one more tiny component of the reason to think about planning for your end of life, because there are things you're not even going to think about. Just like with the lawyer, there are things you never know until you're in the situation. And then all of a sudden, oh, this is why we can't do that, or we have
and I
to
think
adjust.
People don't understand assisted living, and maybe it's different in other states, but assisted living facilities in Washington used to be more assisted. Like there were more nurses. They provided more assistance. It was closer to a skilled nursing facility. Whereas now, an assisted living facility is that people are walking, talking, living in their apartment. They don't have a lot of assistance from somebody else. So it's kind of changed a little bit. And it really isn't the best place for a person to be at the end of their life, because they can't provide the care that that person needs as they become, unable to care for themselves anymore.
We'll save that soapbox for another day. Until then, let's get to our guest.
Yes, let's do it.
Yay, Lisa! Thank you for coming on and being with us.
Welcome.
Thank you for inviting me.
Of course. Tell us a little bit about yourself.
My name is Lisa Yeager, and I am from Virginia, and I'm a member of the Nansemond Indian Nation of Virginia. I have a bachelor's in psychology from the University of Virginia and a master's degree in social work from San Jose State University. I also have a certificate degree from the California Institute of Integral Studies, focusing on psychedelic therapy and research.
I am thrilled to pick your brain about all the psychedelic assisted therapies that you do, or that you've worked with.
Me too. I want to hear all about it. Because full disclosure, I've done psychedelic therapy off the record when I was I don't think you could necessarily call it therapy, but definitely back in the 80s, participated in some psychedelic extracurricular activities. But that's, I'm sure, much different than what you're going to tell us about.
Possibly. Maybe not.
Maybe that's a good place to start.
Okay.
What is the difference between just doing recreational? Well, first, let's back up. let's tell the people, what do we mean by psychedelic and psychedelic
Great idea.
assisted therapy?
Yeah.
Sure. So the classical psychedelics are LSD, psilocybin, otherwise known as magic mushrooms, ayahuasca, MDMA, sometimes known as ecstasy, is not a traditional psychedelic, but it can have psychedelic qualities. Ketamine also has psychedelic qualities, but is not a traditional psychedelic. It's a dissociative anesthetic that has psychedelic qualities to it. There's many other ones, 5-MeO, DMT, peyote, mescaline. So they all are substances, medicines. Some come from plants, some are chemical in nature that create a altered state within the person where they are experiencing visual hallucinations. They may be having auditory hallucinations. They may have mixing of sensations where they smell music or they can feel music, where their senses are kind of mixed. There's like a synergy of the different senses that they have.
Well, I think we can all imagine why people would use it recreationally, but why would someone, instead of just doing what would maybe be traditional talk therapy, why might someone venture into psychedelic assisted psychotherapy, both as the therapist and as a patient?
Sure. Well, if we look back into history, for eons, different cultures have ingested hallucinogens for the benefit of their village, their community, and also for personal healing. So, incorporating psychedelics into having a healthy village, having a healthy self, has really been a huge part of the human experience. And there are lots of different theories as to how that initially started. How did we originally come to know that a particular medicine or plant was going to have those kind of properties? And certainly in the ayahuasca tradition, when ayahuasqueros, the shamans and ayahuasqueras, the women and men who work with ayahuasca, when they're asked that question, they say the plants told us. So that there is this belief within many indigenous cultures that plants, animals, rocks can communicate with us. So there's a long history of humans utilizing psychedelics to gain healing or insight, get questions answered. And so that has been a part of our human experience. Then in the late 50s, early 1960s, we started to have research where folks in the lab were discovering by accident, like Albert Hoffman discovering by accident that, this substance now that we now know as LSD has hallucinogenic properties. And that led other researchers like Gordon Wasson, who is an ethnobotanist, led him to go to Oaxaca in Mexico, and he met Maria Sabina, who is sort of a matriarch for many folks, that she introduced the psilocybin mushrooms to Gordon Wasson. He then took that back to the States. That was eventually synthesized. And the research started around that time of wanting to explore how these psychedelics could assist people who were struggling with depression, who were struggling with anxiety around end of life, who were maybe struggling with drug or alcohol use that was more of an addiction. So the researchers started to become curious as to whether this mind-altering substance, any of these substances, could be of benefit for the different symptoms of distress that a person might be struggling with. And so in the late 50s and early 60s, towards the late 60s, before the FDA rescheduled a lot of these medicines, there were many, many research studies that were going on in Europe, in the United States, in Canada, that were showing pretty positive results, that one high-dose psychedelic session in a supportive environment with what we call a supportive set and setting. So set being the mindset that the person is in, and the setting, supportive environment with therapist guides being with them had the potential to really help reduce symptoms of depression, help reduce symptoms of anxiety around end of life, and also to help with addiction to alcohol and to drugs. There are stories that Bill W., who founded Alcoholics Anonymous, part of his journey towards recovery was having an LSD experience, which really helped him and then led him to formulate some of the 12 steps in the program.
I can imagine a lot of people nowadays are coming as patients because they are resistant to traditional medications. And there's been a lot of good studies about that as far as, especially
Yes.
depression. I know I've seen some documentaries. Wow, words are hard. Documentaries where they've talked about the use of different types of psychedelics to help with treatment resistant depression, PTSD, all of those kind of things.
So we experienced almost a complete stoppage of all of the research when the FDA decided to make all of these substances Schedule 1, meaning that there was not any medicinal healing benefit to them. So they all were rescheduled into that realm, which put a halt to all of the research that was going on. So we lost a huge amount of time, but then the research started resuming in 2017, 2018, looking again at how could these medicines help with treatment-resistant depression. MAPS, the Multidisciplinary Association for Psychedelic Studies, started their focus under the leadership of Rick Doblin to start studying MDMA for the treatment of PTSD. And that's really been their focus. And their results, very high percentage of success with folks that were participating in those studies coming out of the study with a significant reduction in their symptoms of PTSD.
And sorry, Penny, I'll let you go next. I'm just thinking, I think I've heard you talk about, Lisa, a lot of these studies are being done until very recently outside of the United States because of the class that they're the Schedule 1 classification, right?
Not completely. It is possible to do the research with a Schedule 1 medication. There are very elaborate, significant hoops that the researchers have to go through to be able to do that research, but it is possible. So we've had pretty significant studies through Johns Hopkins, through NYU, UCLA. UW is now starting to do some research, San Francisco. So there have been a number of places in the States where we have been seeing some really significant research, and in Europe as well, and in Canada. But it's just an arduous process to get through the IRB and the research, all the steps that you have to go through for Schedule 1. And for the research, they have to use the synthetic version of whatever medicine that they are exploring, because for the research purposes, they have to be able to verify that the amount of the psychedelic medicine is going to be the same in every single dose, which is not possible to do if you're ingesting a mushroom that has grown in the woods or grown in someone's home. That each one of those mushrooms is going to have a little bit of a variation to how much of the medicine it has in it.
Right. I'm guessing that the psychedelic assisted therapy is really truly different than recreational use of LSD, because you're saying that this therapy can actually help people who have drug and alcohol addiction. I did LSD, like I said, in my teens, and an alcoholic and was a drug addict, so it didn't help me at all in that regard. So what exactly is the difference between, just taking it on your own and the therapy part of it in the
A huge part of it is the set and the setting. The set is the mindset. What is the person's intention of participating in this kind of therapy? if a person is ingesting a psychedelic in a recreational setting, their intention is to have fun, have a whatever their experience is, and they may be successful in having fun, or they may have a disturbing experience. We never know. That's true in a supported psychedelic experience too. But the difference is that when a client is coming in either to a research study or is working with a guide or a therapist, their goal is that they have some particular intentions or aspirations that they're coming in with. And they're coming in with that intention. They're working with the researchers or the therapist to really explore their intentions and their hopes for the experience. There's a lot of preparation that goes into supporting that client before they even come in to take the psychedelic medicine. And for many of us, we feel that the preparation work and then the integration work afterwards, those are as important, if not more important, than the actual psychedelic session. So it's really a difference in the mindset of the client, and the setting is also very different, where things are very supportive for that client that's coming in for the psychedelic session. In the recreational world, person maybe is taking it to right before they go to a concert, and so they're in a concert setting with many other people. And in the research or working with a therapist, there's a very safe, supportive environment that is discussed and created with the client beforehand, before they come in, so that they understand what the space is going to be like, what kind of support the therapist or guide can offer, how they are going to be kept safe, how they're going to be supported. So it really is very, very different than the recreational choice to take a psychedelic versus having a supported psychedelic session where someone is there with you for that whole time, supporting you, holding space, and helping to potentially navigate through difficult arenas that may come during the journey, that come for the reason for healing. We say that there aren't any bad trips. There can be difficult moments within an experience, but they're coming for a reason.
Well, I think that talk about preparation and the integration afterwards is so vital of a conversation. Number one, because we're thinking about people that are coming in to treat what could possibly be a trauma event, PTSD, and for veterans, that's really a big push right now, is to get that integrated and in work for PTSD. And if they do have a challenging experience in the middle of that session, that you have a trained professional there with you. And I really want to mention that because of these, now that because ketamine is a legal substance in the United States, that there are these ketamine clinics popping up now, and they're not necessarily clinics that have supportive therapy along with them. So can you just differentiate that for the listeners, for people don't just go out and pick the first available ketamine session that you can get into. There are reasons not to do that.
Yes, there definitely are reasons not to do that. Ketamine is in a different category. So it's a Schedule 3 medication, which means that it can be prescribed by physicians for a variety of different things. It's a dissociative anesthetic, and it's often used in military settings. They would use it out in active wartime, where they could give pain medication very quickly to get a soldier in to be able to get treatment. It's used in the emergency room setting really quite frequently. That's where I first encountered it when I was working as an ER social worker. And then it has this ability to be a dissociative anesthetic and psychedelic. And so we're using it in an off-label method, which has been approved by the FDA. But there are many different ways that ketamine can be administered. So it comes in a sublingual lozenge form that we can give that in a tablet, which, as Halley can remember, it does not taste very good. Well, and chocolate raspberry flavoring did not help, I don't think.
It did not help, no.
Yeah. At our clinic here in Bellingham, we experimented a little bit with different flavors and kind of landed that mint is probably the safest bet. So it's got that yucky medicine taste with a little bit of mint flavoring to it. So there is the sublingual administration. It can also be administered by a nurse or a physician intramuscularly, either into the bicep of the arm or into the buttock. It can also be administered by an infusion, so that requires a nurse or a technician to start that IV and give and administer it in an infusion. So there are big differences. Some of the infusion clinics typically do not offer any kind of therapy along with the treatment that they're offering. So the client comes in, they get an assessment, they come in, they get their ketamine treatment via infusion, and there isn't really any support, therapeutic support that's offered to them during their ketamine experience, and not really anything offered afterwards. They are sort of left up, it's up to the client if they have a therapist that they're working with on their own. And so that can lead to some, potentially disturbing experiences or something that's kind of just disrupting their view of the world. And they don't really have the support in place in many of the infusion clinics. And that can be true in some circumstances in the clinics that are just offering intramuscular injections as well. Myself and the physician that I work with and my therapist colleague, we were all trained to provide ketamine assisted therapy. So it is the combination of receiving the ketamine treatment and receiving therapy. So they work with us for preparation counseling sessions to get them prepared and help them to hone in what their aspirations and hopes are for the ketamine experience. And we also prepare them for the fact that there could be some difficult aspects of the ketamine journey. And we prepare them for that and say that this is normal, this may happen. If it does happen, it's not going to be a long experience. Everything is always changing within the psychedelic experience. And then we're working with them afterwards to help make sense of what happened during their journey. And so in our training, we really believe that that's where the most success can happen. The most healing can happen is that they have a supportive person that's helping them with the preparation, is there with them for their entire ketamine session, following up with them afterwards, and then doing integration work to help them make sense of what they experienced. It can be really important. And our goal with ketamine assisted therapy is that the person is going to have enough of a reduction in symptoms so that they don't need to continue to have the ketamine treatment, which is a big difference between the ketamine infusion clinics. It's a maintenance program where the expectation is that the person is going to, maybe they come in twice a week for a little while, then they taper to once a week, but they're continuing to come in. There isn't really the goal that the person is going to have a full reduction in their symptoms, that they're going to come in to have sort of a maintenance. So it's not that much different than taking an antidepressant.
And is the purpose of the ketamine infusion clinics to address mental issues? Mm-hmm. Okay. Mm-hmm. Because I'm thinking dosing must play into this somehow, because we use ketamine at my hospice agency for pain management. We use it IV and we use it orally. My first experience with giving a patient oral ketamine was in a hospice care center, and it did not go well because that patient, and this was for pain, but that patient experienced a lot of hallucinations and was very, very disturbed, and we had to stop giving it. So dosing, like, are you giving more? Or are you doing microdosing? Like, what's the difference in dosing when it comes to treating pain so that you're not going to get these hallucinations and things that is actually kind of the goal with the therapy, right? Is it more that you use or less that you use? What's the difference there?
The sublingual lozenges are a little bit less in the dosage. Our lozenges are 100 milligrams. And so we can incrementally go up with the dosage. And the benefit of the lozenges is that it has a gradual coming on to the intensity. It takes about 30 minutes or 35 minutes to get into that peak ketamine experience, which is usually about 45 minutes long. And then there's a gradual coming out of it. And so that's can be much more gentle for clients to experience it with that lower dose. They definitely can have a psychedelic, most of them have a psychedelic experience with the dosing that we use, but it's a gradual going in and a gradual coming out. Whereas with the intramuscular injections that we offer, the client is feeling the ketamine and in that space potentially within like 2 minutes. So they're sort of launched into that deep ketamine experience very quickly, and they're in the deepest part of that, and then they come out more quickly.
And Penny, I
And
think
so with the,
to speak to your question, I know when we've used ketamine lozenges for pain in hospice, it has been a much lower dose for pain management, closer to the dissociative side, for relief of their pain, but not necessarily dissociative out of their body, which is closer to the hallucinogenic side, right? Am I understanding that right?
Right.
Do
And
you
with the
do
infusion
ketamine?
at the infusion clinics, they're using a dose where they can have somewhat of a hallucinogenic experience. They, I think, typically allocate about 2 hours for the person to be there to get their infusion. So they're using that sort of dosage, which I would agree with Halley that for pain, it's usually a lower dose where we're trying to address the pain without creating that hallucinogenic experience that the patient might not be prepared for.
Okay, yeah. Right. That makes sense. Yeah. We're doing a continuous infusion too. We're not doing like a 2-hour blast. It's a continuous, probably low dose infusion.
Yeah. And it's important to, talk with clients about, or patients about the fact that they could experience something hallucinogenic, a psychedelic experience when they're getting ketamine for pain, to be able to prep them for that. I've heard a story or two of a woman in labor who was given ketamine because of some aspect of her labor experience, and she started to have a hallucinogenic experience while in labor and was not prepared for that. And it was very disturbing.
I think that's probably my biggest worry with the use of ketamine in an ER setting is people in a mental health crisis. Ketamine does intramuscularly, like you said, work very, very quickly to subdue someone, but it also can exacerbate whatever psychotic break they're having.
Right. Exactly. I mean, when I was working as an ER social worker, I was not aware. I don't know at that time if they were using ketamine on the ambulance rigs, because if it is a paramedic who can administer medication, they can call into the ER doc and get the order to be able to give ketamine. I don't know if they were doing that because that was back in like 95 to almost 2005. But that in the more recent history, that has been something that a paramedic out in the field could get an order to administer ketamine to someone who's having some sort of a mental health crisis, and they get injected with ketamine without any kind of warning. They don't know what's going on. They're in an ambulance rig with really bright lights, and it's most likely not going to go very well.
We used to give ketamine to cats for spaying them, and they would go ballistic when you gave them the injection. The first time I ever heard of ketamine was when there was a movie called Perfect Victim, and it was about some guy that was administering ketamine to some women. And then, they were showing you in the movie this dissociative state that they had. And then he was, raping them and torturing them and everything else. But that was the first time I'd ever heard about it, and that it was a horse tranquilizer.
Right.
So then now when I worked in the ER, there was never a time when I gave ketamine to a patient and I only worked in the ER for about 3 months. But so the first time I ever heard about using it first on cats was like, that's interesting because this is a horse tranquilizer. But then when I worked at the care center and we got the order to give it to the patient orally, I was like, wait a minute, isn't this a horse tranquilizer? So, but yeah, I just always remember those cats going crazy when we gave it to them. So imagine that it probably has the same kind of dissociative effect on them.
Definitely. And my first experience with ketamine in the emergency room setting was with a patient who had come in, and he was a roofer, and he had gotten splattered with hot tar all over his chest.
Oh,
and they needed to, get the tar off, and they didn't want to, that was going to be excruciatingly painful to do without giving him some kind of medication. And they gave him ketamine, and he was awake and looking around, but totally dissociated. And they didn't have to, it doesn't suppress the breathing, so they didn't have to worry about him needing to be intubated. He was dissociated, looking around. They were able to get the tar, pull the tar off of his skin. And I sat with him afterwards, and I was like, do you remember anything of what happened? He was like, nope, even though he was awake. And I've seen that with clients that I'm offering ketamine assisted therapy to, that sometimes they will take off their eye cover and they are looking around, but they are not seeing me. They are seeing something totally different.
Okay, so now you've piqued my interest with the eye cover thing. So when you're doing this ketamine assisted therapy, are you blindfolding them?
It's an eye cover. We recommend something called a mindfold, and it completely blocks out any light. But it has little cups so that you can open your eyes completely, but you're not seeing any light. And so it's an invitation for the client to go inward, to have that inward experience. And some people do have those visionary states with ketamine. It's not quite as psychedelic as LSD or psilocybin or ayahuasca. It really kind of varies from person to person. Some people will see bright colors and will have visionary experiences. Other people, it's more muted colors or grays. And then some people don't have the colors and sights in that kind of way. But having that eye cover on is an invitation to go inward and to not be distracted by the things that are around them.
Well, that makes sense, because I can remember being very distracted by a bag full of onions in the basement when I when I did LSD the first time. God, it looked like a monster.
Yeah, things look very different. I mean, I can remember one of my first experiences with LSD, coming back on public transportation after seeing the Grateful Dead, which is sort of the door of entry for many people. We were coming back on the BART train, and the carpet was just fascinating with all of the changes and shapes, and how it was undulating, and
So do you do other psychedelics for your assisted therapy, or just ketamine? Or do you use ayahuasca or LSD or anything like that? Or is it strictly ketamine? And if so, why?
Well, ketamine is the only medicine that is legal to administer to clients at this point. So that's what we offer at our clinic here in Bellingham. That's called the Bellingham Ketamine Clinic. And that's what we're offering at this time. We're hoping, since all three of us at our clinic, we all went to the California Institute of Integral Studies, so we're all trained to work with psilocybin and MDMA. Our hope is that we can expand to those medicines once they get rescheduled.
And I think Oregon's working on something like that, right? With psilocybin?
Oregon is now legal. They passed a law, I think it was 3 years ago now, and it took them, they took their time in trying to get all of the regulations and certifications in process. And so now they do have psychedelic centers that offer psilocybin to clients. So it is possible to go have a psilocybin session legally in Oregon. And you don't have to be an Oregon resident to be able to access that. And then Colorado has more recently passed a law legalizing psilocybin therapy, and they're now in the process of getting their regulations in place so that they can offer that legally too. So it's legally within the state of Oregon and will be legal in Colorado, but is still federally illegal.
Oh,
How does that work?
well, same as medical aid in dying and
Yeah,
pot.
I guess so.
And if the federal government, chose to focus on that, they could come and shut down those treatment centers if they wanted to.
I imagine ketamine is a little easier to work with on a therapy level because it doesn't last as long either.
That's very true. So an LSD session could be 12 hours, 10 to 12 hours long. An MDMA session is usually around 8 hours. Depending on the person, a psilocybin session is about 6 hours. Ketamine we allocate 3 hours for our ketamine sessions. And so it's easier on the client. It doesn't interact with other medications in the same way that other psychedelics do. So that's a benefit for working with someone who is struggling with depression and anxiety, that they don't have to taper off of their medications typically to have a ketamine experience, and they can still get the benefits from the ketamine. And in working with clients who maybe are on hospice or palliative care, it's also a benefit that it's in shorter duration. If you have a hospice patient or a palliative care patient that is experiencing anxiety, that it's an easier to manage 3-hour session. And it also doesn't interact poorly with some of the different medications that someone on hospice or palliative care might be taking.
Okay, first, Halley, stop throwing your furniture around.
I'm sorry.
I don't know what you're doing. It's banging, banging, banging. But then the question I have is, so during the session, when they're doing the ketamine, are you asking questions? Are you talking to them? Or what kind of therapy is happening as they are experiencing their trip, if you will?
Our approach is really to be non-directive. That our goal is to be there, participating by being in the process of doing by not doing. So we're holding safe space for them. We're there to offer support if they request it, but we're also there not to intervene in the process, because we feel, or at least I feel, that there is an intuitive healer within each client, and this is an opportunity for that intuitive healer to come forth and maybe have some conversation with the ketamine. My role is to offer that safe container for them and to then offer support if they request it, but not to interrupt. So if they're crying, I allow them to have that emotional expression. I wait for them, and I coach them about that beforehand of, this is your role to reach out to me if you need support, so that I'm not interrupting the process of what you're experiencing. And a client will, say help. They can say something just as simple as help or reach out their hand. And so we talk in advance about what kind of touch would be supportive and consensual. So can a hand on the shoulder for support, or if they reach out their hand and would like for me to hold their hand. Sometimes putting the hands on the bottom of the client's feet for grounding. So those are some of the things that I do in terms of offering support. Some people are wanting to verbally process, and when they start to verbally process, then I'm taking notes for them, and I will try to offer them support as they're processing what they're sharing. But I'm really following their lead in terms of what they might need during the session.
So I'm guessing insurance doesn't cover this, since it's not a federally legal program. Is it expensive?
That's a tricky part, unfortunately. We can bill insurance companies for the prep and the integration sessions that we offer using the standard code for therapy. But the ketamine sessions themselves that we offer aren't covered by insurance. No insurance company is covering that kind of ketamine assisted therapy at this point. Interestingly, the infusion clinics, they can bill insurance for the type of infusion that they're offering. And they can also bill if they're offering Spravato, which is S-ketamine. So it's ketamine that has been modified slightly in the molecular structure, and so it's been patented by Johnson and Johnson, and so that is covered by insurance companies.
Yeah.
So what is the ketamine portion of the session cost? Ballpark.
At our clinic, we do offer a sliding scale because we don't want to turn anyone away, and so our sliding scale is $350 to $550 for a ketamine session.
I have so many soapbox thoughts about insurances and what they will and will not cover. So we don't have time for that.
Yeah, I share your sentiment, and it's a whole different perspective of, do you want to encourage a client to be well and not need you anymore, or do you want to encourage maintenance on something that keeps them in the system?
Yeah, we all know the answer to that, right?
Yeah.
Keeps
Yeah.
you
So
paying money. So, it's interesting because in Canada, they keep pushing this law out. People think it's active, but from what I understand, it hasn't been yet, that people can access medical aid in dying for depression. And it seems like, to me, like, why wouldn't they instead do with, something like this, first, or require this first before allowing somebody to, legally end their own life because of depression or mental illness. It seems like it could be another alternative to that.
And in Canada, they do have they have something called the right to try in Canada. And so there have been a number of clients in Canada that have been able to go through a whole application process to be able to legally have psilocybin assisted therapy. Initially, they were clients who had a terminal illness, and my understanding, I'm not 100% sure, but my understanding is I think they have had a couple of clients who have gone through that process, who had treatment-resistant depression as well, and they were granted access to be able to have supported psilocybin therapy. So in Canada, they're trying.
I know you do individual sessions and group sessions. Maybe you can speak a little bit to the benefit or not of either one and why someone might do that in a group rather than individually.
Well, the group sessions, that's a great question. Thank you. The group sessions can lower the cost, so that's one benefit. And there can be an additional layer of healing that can come in a group setting where there's a sort of a synergy that can happen with the members of the group. And there's also the benefit of the integration work in a group setting afterwards, where they're able to connect with other people who are struggling in similar ways to how they're struggling. And that can be really helpful because we know that mental illness is often very isolating. So for those clients to be able to connect with other people and who share similar stories, and then they can kind of support each other through the ups and downs of what they're experiencing. And so there are benefits, I think, to individual and group. My process is that I think it's important for the person to have one or two individual sessions first before they consider going into a group experience.
I know you've worked in hospice bereavement as well. How do you feel about this psychedelic assisted therapy for grief rather than like a treatment-resistant mental illness?
I think that it can be very powerful. I think all of the psychedelics could be very powerful in helping with grief and anxiety. And I believe that ketamine is definitely one of the tools that we can use. I would say probably 99% of the clients that I have worked with ketamine, we all have experienced some level of grief in our life. And inevitably, I would with 99.9% of the clients at some point in their ketamine work, grief comes up. And then we work with that and we look at that. And oftentimes there is an opportunity to maybe look at the relationship that they had with their loved one in a different way, and maybe find some completion and acceptance in a different way. My name is my very first ketamine client when we first started. His father was deceased, and he had a complicated relationship with his father, and he felt like he was okay in being in a place of acceptance around that. And in his very first ketamine session, which he was coming in for depression, he had a powerful experience with his father within that ketamine experience. And it brought a whole nother level of healing. And he came out of it saying, I had no idea that was there still. I had no idea. And it was really profound for him.
Mm.
So I think there's a lot of potential to be able to access ketamine as another tool to help people who are experiencing grief.
I love that. Well, I want to be mindful of your time. So in these last few minutes, is there anything that we haven't covered? I know we've pretty much been talking mostly about ketamine, and that is because it's the one legal use here. But is there anything else that we haven't covered that you want us to know about psychedelic assisted therapy?
Well, I think to keep in mind that all of these psychedelics have huge healing potential in the proper setting where there is a safe container. And there can be difficult experiences that can come even in that safe container. And with the proper amount of support, there can be a lot of healing that can come from that.
I can appreciate that. I'm going to switch gears real quick before we let you go, and I'm going to ask you our new season 2 coffin question. What do you want to have done with your body when you die?
That's a good question. Because I think about that doing this work for as long as I've been doing this work. I think about that. I had initially, for many years, I thought cremation was the route that I wanted to go because it's kind of simple and okay, box of ashes. Someone can decide what to do with the box of ashes. But, as I think about that more and more, the impact that has on the environment leads me to be less inclined to that. So green burial, I think, is the direction. I know I have a friend who has a funeral home, and he offers a lot of different alternatives in terms of the aquamation and the human composting. But green burial, I think, is what appeals to me the most. And there are a couple of places that you can do that.
Nice.
So that kind of appeals to me. I would like to, and I think that's connected with my indigenous roots. That in my lineage originally, that's what would happen. We would be either in my lineage, we would be buried in the ground, and so that really appeals to me. And I've participated in a couple of green burials, and they're really beautiful in terms of the ritual that can be incorporated in that process. And I would kind of like to go back to the earth. And since I'm so connected with mushrooms, I would like to, I love the vision of my body somehow being nutrients for mushrooms.
I love that.
Well, Lisa, where can people find you if they want to know more about ketamine or whatever else you're offering to the world?
Sure. Well, so I do have a private practice, and you can find me on Psychology Today with my profile, and my private practice is focusing on grief therapy, depression,
and that's traditional
anxiety.
talk therapy, right? Not psychedelic. Okay.
That's traditional. So I offer traditional talk therapy. I also am offering nature therapy. I have a geodesic dome with trails that are connected with that. And so for some clients who want to do nature therapy, walking and being out in nature as a part of the therapeutic process, that's available. So on Psychology Today, if you look up Lisa Yeager in Bellingham, Washington, you can find me there. And then our ketamine clinic is the Bellingham Ketamine Clinic, and I'm there offering ketamine assisted therapy.
Excellent.
And then lastly, my colleague and I are also now offering trainings for clinicians who want to learn more about ketamine and want to have a ketamine experience as part of the training. And so that is another offering that we're putting out there into the world. So we have another training for clinicians on November the 23rd, I believe, which is a Saturday.
Wonderful.
And we're hoping to broaden that out. Maybe at some point trying to collaborate with some mindfulness instructors, because we've had some experiences with clients who are doing mindfulness practices that in combination with the ketamine therapy can be really beneficial. So that's something that we're brainstorming about, of how we can combine some mindfulness practices with ketamine experiences. And we're also thinking about how we could offer ketamine experiences and support to caregivers and hospice staff, recognizing that hospice staff experience levels of burnout, and how could a ketamine experience be a way to help them reset a little bit and get some support.
Are you on social media? Do you have a social media platform?
We're on Facebook, but not on any of the other platforms.
What's your Facebook username?
We don't actually have one for our ketamine clinic. We're sort of not super social media engaged.
Well, you're going to have to get that way if you want to start training people.
It's true.
Yeah.
We'll get you there, Lisa.
Yeah.
Thank you so much for coming on with us today.
Being on.
Thank you for having me. It's been a pleasure to chat with you both.
Yeah, thank you. So when I was doing acid back in the 80s, never did it cross my mind that potentially that type of drug could be used in the future for therapy for people. And wow, have we come a long way.
Yeah, and so much further to go.
Oh, yeah, I was going to say, it'd be great if we could go even further and make it legal. And, I think it sounds really interesting and could really help a lot of people.
Well, I
fascinating.
Think we really didn't have, there's so much to know, and Lisa is just this wealth of knowledge of the history of it and what that looks like. But I think it's helpful for folks to know what that actual experience is. I went through the ketamine process twice. I went through it with the oral lozenges and with the intramuscular, and I have those documented. I don't talk about my other podcast that I have not updated for since we started this one, but if you really want to hear about it, you can go to Someday We'll All Be Dead. It's on all the podcast platforms. And I do have a documented 2-part series about our psychedelic experiences with ketamine. But it is some of us had not very much of an experience, and some of us had life-changing, world healing connections with everything experiences.
Wow.
So yeah, it was really amazing. And that's one of the reasons we've all stayed connected, I think, is not only did it help us personally, but also help connect us as clinicians together. And we've stayed connected in that way because we have this bond now.
Well, and we didn't really talk a whole lot about the benefit for hospice patients. We talked about it a little bit offline, but, being able to address people's fear and anxiety, especially when they first get that terminal diagnosis, could make for such a better death experience for them and for their family if they could go through this ketamine assisted therapy and really
upstream would be amazing.
Everything. Yeah, because we see so many people, not so many, but we see enough people who have terminal agitation due to existential suffering that we sometimes end up having to sedate until their death. And how much better would it be if we could let them work through whatever it is that's really troubling them so that they could have a peaceful death and go, without having the burden of whatever it is that's distressing them on their heart and on their mind.
And it really, I mean, the studies that have been done have shown, a reduction in death anxiety. So we're specifically talking about not just healing of depression or healing of trauma, which absolutely can lead to this terminal agitation that we see, but also
Mm-hmm.
just general death anxiety. What is it going to be like when I die? I'm afraid of what's going to happen, or actually going through the death process. And it really has been shown statistically significantly to reduce the anxiety around that. And so then by the time they get to that end of life, last 6 months hospice experience, then they can be focusing on what's important and not worrying about their anxiety management, which is going to make them sleepier because then they're on more meds.
Right. Exactly. Exactly.
Yeah. Long way to go,
Fascinating.
but I'm glad we've started it, and I'm glad we've opened up the conversation. So
Yeah, me too.
baby steps.
Yeah.
Well, in the meantime, look, if you're going to listen to this out there and think that ketamine or MDMA or ayahuasca, which we didn't really talk about because it's definitely not legal here, but I cannot imagine myself puking my guts out for days. If you're going to go explore that, make sure that you're doing the research, that you're not just going to freaking Joe Schmo down the road. And just because insurance pays for it doesn't mean it's the best option.
Right. Right.
Good Lord. And until then, remember to live, because someday
We'll all be dead.